or portosystemic encephalopathy. Hepatic encephalopathy or portosystemic encephalopathy is a condition characterized by neuropsychiatric conditions, the neuropsychiatric symptoms where the patient will have alteration in mental status and cognitive functions due to secondary chronic liver diseases. This is the definition of hepatic encephalopathy or portosystemic encephalopathy. It can be of two types, that is acute and reversible type and chronic and progressive type. Acute reversible type is usually secondary to acute fulminant hepatic failure. Following reversal of the injury which is causing acute fulminant hepatic failure, we will see the reversal in hepatic encephalopathy. The chronic progressive one is secondary to cirrhosis. Now, what is the etiopathophysiology behind hepatic encephalopathy? Almost all the damage is caused due to gut-derived neurotoxins. From where does gut-derived toxins come to the body? Reach the brain. The bacteria in the gut will break down the proteins and amino acids to release ammonia, aminobutyric acid or mercaptones and other gut-derived neurotoxins. Among these gut-derived neurotoxins, ammonia is the most important gut-derived neurotoxins which causes impaired functioning of astrocyte. So these gut-derived neurotoxins, normally these are produced in gut, meaning in all the normal individuals also these gut-derived neurotoxins are produced, but they are detoxified in the liver following their production. But in case of patients with cirrhosis and portal hypertension, we know they will have portosystemic anastomosis. Due to portal hypertension and cirrhosis, the blood will reach the systemic circulation directly without reaching liver, where it should be detoxified. Portosystemic anastomosis. So the neurotoxins directly enters the brain. And also, since the detoxification function of the liver is lost due to its injury, the gut-derived neurotoxins will easily gain access to brain. Astrocyte, which are the support cells for neurons, their functions will be impaired. The level of glutamine inside the astrocyte will increase due to these neurotoxins. The increase in glutamine inside the osmocyte, inside the astrocyte, will attract water molecules into it, causing astrocyte swelling. And then with astrocyte swelling and impaired blood-brain barrier, there will be cerebral edema. In fact, in acute cases, secondary to cerebral edema, a patient can develop herniation and the symptoms associated with it. We saw due to gut-derived neurotoxins, there is astrocyte swelling, increased glutamine levels, cerebral edema, and herniation. And this gut-derived neurotoxins also increases the level of inhibitory neurotransmitters like GABA and decreases the level of excitatory neurotransmitter like glutamate. They have effect on neurotransmitter levels. On top of this, these neurotoxins will impair the energy utilization by the CNS, that is brain, by affecting amino acid metabolism. So now the brain there is cerebral edema, impaired alteration in the neurotransmitter levels in brain, usually causing CNS depression due to increased inhibitory and reduced excitatory. And also there is reduced energy utilization in the brain due to impairment in amino acid metabolization. All these are responsible for the symptoms that we see in hepatic encephalopathy. We have certain precipitating factors which precipitates the hepatic encephalopathy. Those are the factors which increase the gut-derived neurotoxins, like constipation, which will not allow the contents inside the GIT to pass, thereby increasing the gut-derived neurotoxins. The increase in protein load, either due to increased dietary intake or following GI bleed, there will be increased proteins inside the GIT. This increased protein load is available for bacteria to act and convert it into gut-derived toxins, thereby precipitating hepatic encephalopathy. The acute decrease in hepatocellular function, whether it may be due to viral hepatitis or other causes, also precipitates hepatic encephalopathy due to reduced detoxification of the gut-derived neurotoxins. Hypokalemia and hyponatremia also precipitates hepatic encephalopathy because we have impaired water homeostasis inside the brain. You can see cerebral edema is there and the blood-brain barrier is impaired. Due to these electrolyte impairment, it exacerbates the pre-existing conditions in the brain. So large volume paracentesis in case of ascites will precipitate hepatic encephalopathy. Overuse of diuretic leading on to hypokalemia and hyponatremia precipitates hepatic encephalopathy. Vomiting and diarrhea causing hypokalemia and hyponatremia will precipitate hepatic encephalopathy or portosystemic encephalopathy. What are the clinical manifestations seen due to these etiopathophysio processes? Early in the disease, the patient only have mild impairment in the cognition. He will not be in his optimal state. He will have attention deficit and psychomotor abnormality. One of the initial symptom is inversion of sleep rhythm, meaning the patient will be more sleepy during the day and he will be sleepless during the night time. Inversion of sleep rhythm is one of the early symptom. With increasing severity of the disease, the patient will first develop confusion, then restlessness, and then drowsiness, where the consciousness will be impaired, but the patient will be responsive to verbal stimuli. Then the patient may progress into stage of stupor, where the patient will not respond to verbal stimuli or other normal stimuli. He only responds for painful stimuli. At the last, the patient can reach coma, where he will not be responsive even for painful stimuli. These are the clinical manifestations that we see. Based on the severity of clinical manifestation, the hepatic encephalopathy has been graded into grade 1, grade 2, grade 3, and grade 4. In grade 1, the patient will only have depression, mild confusion, or reversal of sleep rhythm. In grade 2, he will have moderate confusion, mild confusion in grade 1, moderate confusion in grade 2, and marked confusion in grade 3. Along with moderate confusion in grade 2, the patient will have lethargy. In grade 3, the patient will have marked confusion and sleeping but arousable, meaning he will be drowsy and he will be in stupor state. In grade 4, the patient will be in coma. Initially, he will be responsive to noxious stimulus, meaning he is in stupor, later progress to coma. These are the 4 grades of hepatic encephalopathy. Now, also, what are the examination findings that we see in hepatic encephalopathy? We characteristically see flapping tremors or asterixis, where if we ask the patient to extend his arm and extend his hand at wrist, we will observe the flapping tremors at the hand, at the wrist after a few seconds. This is called as asterixis or flapping tremors. Other examination findings can be constructional apraxia, meaning if we ask the patient to construct star, he will not be able to do star. If we ask the patient to construct triangle, square, he will not be able to do these structures. He will have constructional apraxia. If the disease become very severe, you may have bilateral extensor, plantar response, that is Babinski positive. Along with all these signs and symptoms of hepatic encephalopathy, the patient will obviously have signs and symptoms of hepatic insufficiency, like he may have sweet musty odor called as fetor hepatitis due to increased mercaptone level, which is a gut-derived protoxin, mercaptone, along with is most important one. Then the patient will have spider nevi, edema, ascites, pleural effusion, and all the other clinical manifestations that we see in hepatic insufficiency. Now, how do we manage these patients with hepatic encephalopathy? Under investigations, we check blood ammonia levels. It will be obviously elevated. but the severity of disease doesn't correlate with levels of ammonia. We see ammonia is not the only toxin, gut-derived neurotoxin, which is causing all these manifestations. We have aminobutyric acid, mercaptones, and other fatty acids, etc., which are causing these. So the ammonia level doesn't correlate with disease activity, disease severity. On performing EEG, electroencephalogram, we saw there is cerebral inhibition, cerebral depression. We'll see diffuse slowing of normal alpha waves. With increasing severity, we'll see delta waves. Delta waves are seen in deep sleep, that we'll see in patients with increasing severity of the disease. To rule out causes of coma and drowsiness stupor, we check for serum glucose level, where the patients with hypoglycemia can present similarly. We check urea creatinine level to rule out CKD and uremic encephalopathy. We do CT and MRI because rarely the patients with hepatic encephalopathy may have focal neurological deficit. So rarely we may have to rule out stroke in these patients. So to do that, we can perform CT and MRI. Now, how to treat these patients? Please avoid all the precipitating factors which I mentioned during idiopathophysiology. That is, avoid large volume paracentesis, avoid overuse of diuretics, and if the patient has constipation, treat adequately. And also the protein load, it should not be very high. The patient should be advised, the dietary advice should be strict, and it should be clear to restrict dietary protein, and the patient should prefer plant sources of protein rather than meat sources for protein. Then we can give oral lactulose 30 mg TID or QID, that is 3 times a day, 4 times a day initially, which can be titrated till the patient has 2 to 3 soft stools per day. How this lactulose acts in hepatic encephalopathy? Lactulose is converted by gut bacteria to short chain fatty acids. This short chain fatty acids will cause colonic acidification, the acidification of colonic contents. This will cause conversion of ammonia, one of the most important gut derived neurotoxins, to be converted into ammonium ion, which is not absorbed, which is excreted on stools. So thereby reducing the most important gut derived neurotoxin, that is ammonia, can be done by giving lactulose. We can give rifaximin 400 mg TID because we know the gut bacteria are responsible for formation of gut derived neurotoxins. So if you reduce bacterial load, it can help in treating hepatic encephalopathy. If the patient is agitated, we can give oxazepam. This is all about hepatic encephalopathy. To summarize, hepatic encephalopathy is a neuropsychiatric conditions characterized by alteration in mental status and cognitive functions due to secondary chronic liver failure, liver disease. It can be acute and reversible, and chronic and progressive one. Idiopathophysiciology, we saw it's due to the gut-derived neurotoxins. The bacteria in the gut will convert amino acids into ammonia. The ammonia which are produced and other gut-derived neurotoxins like aminobutyric acid and mercaptones are normally detoxified in the liver, which is not done in case of cirrhosis and portal hypertension patients. So through systemic circulation, this gut-derived neurotoxins reaches the brain. In the brain, these gut-derived neurotoxins cause the astrocyte impairment. The functioning of astrocyte is impaired, causing increased glutamine, which attracts water and causes cerebral edema and rarely herniation. Also, these gut-derived neurotoxins will increase the inhibitory neurotransmitters like GABA, decrease the excitatory neurotransmitters like glutamate. Also, they cause impairment in amino acid metabolism, causing impaired energy utilization by the brain. The precipitating factors are constipation, increased protein load, viral hepatitis, large volume paracentesis, overuse of diuretics, vomiting, and diarrhea. The clinical manifestations early in the disease, the patient has mild cognitive impairment, attention deficit, psychomotor impairment, and initially the patient will have inversion of sleep rhythm. With increasing severity, the patient will have confusions, restlessness, drowsiness, stupor, and coma. The grades are grade 1, 2, 3, 4 according to the increasing severity of hepatic encephalopathy. Associated with these symptoms, on examination, the patient will have flapping tremors or hysterexis, and he will have constructional apraxia. Also, he will have signs and symptoms of hepatic insufficiency like sweet, musty odor, bitter hepaticus, spider nevi, edema, ascites, pleural effusion, bleeding, chymosis, bruising, etc., etc. On investigation, there will be increased level of ammonia. On EEG, it shows diffuse slowing of alpha waves. To rule out other causes, we estimate serum glucose level, urea, creatinine, CT, and MRI to rule out stroke. Treatment, we avoid precipitating factors, and orally we can give lactulose 30 ml TID or QID, which is titrated till the patient develops 2 to 3 soft tools per day. We can give rifaximin 400 mg TID so that it reduces the bacterial load, thereby decreasing gut-derived neurotoxins. We should restrict dietary protein intake in these patients, and we'll tell the patient to prefer plant sources. The oxazepam is used to control agitation. Thank you for listening.